Good evening, everybody. Good evening. Thank you so much for joining me tonight on YouTube Live. I'm Dr. Howard Elkin, the medical advocate. And tonight we're going to focus on diabetes. After all, November is American Diabetes Month. And diabetes is really, truly a global epidemic. It's the seventh leading cause of death in this country. But more than that, it's just so huge. I mean, 37 million people in this country alone have diabetes, which is 11% of the population. And 21% of these people is undiagnosed. They don't even know they have it. And most are suboptimally treated. And it just amazes me that this happens. And I know I get a lot of patients, and since I'm a cardiologist and integrative with that, I see a lot of people with diabetes and prediabetes, and I see how they've been treated by other physicians, including endocrinologists. I'm much more aggressive in treating these people than they are. And not that I'm any better, it's just that I take this disease very, very seriously. Now, the future does not look bright for this disease. I mean, if I said it, there's 37 million now, by the year 2050, they estimate it's going to be 55 million people with diabetes. So it ain't getting better, okay? And this doesn't even take into consideration your pre-diabetics. And we'll define what these are in a few minutes. But pre-diabetics, that's almost 90 million people in this country. So it's just an enormous problem. Now, just a little bit of refresher here. So you have type 1 diabetes, which we used to call juvenile onset. And that's really, we see that in children. They have a total lack of insulin. Their islets of Langerhans, which is in the pancreas itself, which is where insulin is produced, it's actually been damaged as an autoimmune condition, which the body destroys itself, at least that particular part of the pancreas. So they cannot live without insulin. But that's about 10% of the population. About 90% or greater have what we call adult onset, which we used to call. Now we call it type 2 diabetes, only because we're now seeing children with type 2 diabetes. I mean, I don't have to tell you, the obesity rate in children today is phenomenal. It's pretty severe. So we're seeing it in children, which when I was a student, I never saw type 2 diabetes in a child. I only saw it in adults. Who's most prone? Well, everybody's prone, but specifically we see it more heavily in Hispanic population, African American, American Indian, and also the Asian population. So I just talked about the prediabetes. There's also something called metabolic syndrome, which you must also learn about. So metabolic syndrome really is it's a cluster of 5 different abnormalities. Number 1, fasting blood sugar is elevated. Number 2, blood pressure is elevated. Number 3, triglycerides are high. Number 4, HDL or healthy cholesterol is low. Number 5, increase in abdominal girth or abdominal obesity. Now, you may say, well, how does that apply to? Applies to a lot, because there's this NHANES study, which is sponsored by the government, and it was by the University of North Carolina in Greensboro, pre-COVID, and they determined that only 12% of the adult American population in this country is metabolically healthy, which means 12%, which means 88% are not healthy. Well, as you can probably imagine, this got worse with COVID. Now it's thought to be maybe just 5% of the nation's population is metabolically healthy. I mean, this is really bad news. So what is the main deal? What is the common denominator in diabetes, prediabetes, metabolic syndrome? It's insulin resistance. Okay, now insulin is a hormone secreted by the pancreas and has a central role. Its role is to take sugar from the gut after you ingest a meal and shuttle it to the liver and to the muscles for storage, and a little bit for the brain. But it really is to be stored. But when you have insulin resistance, either the body's resistant to your own insulin, or it doesn't utilize it correctly. So the insulin stays in the bloodstream. There's like a lock and key. The lock is closed and won't open, so it can't get into the muscle cells. It can't get into the liver, so it hangs out in the circulation, and your pancreas says, "Oh, wow, that's not good. I better produce more insulin." So the body compensates by producing even more insulin, and that's the result of insulin resistance, which is really the common denominator for all these metabolic problems that we're discussing. And we'll talk about prevention in a few minutes, but it's really that simple, right? Which seemingly so. So insulin resistance is the main problem. And then what's happening, more and more insulin is being produced by the pancreas because it doesn't really realize what's happening. So that's how it works. But folks, make no mistake about it, this is a crummy disease. This is a bad disease. I mean, 70% of diabetics will have a stroke or heart attack in their lifetime, which is why I treat these people as if they already have heart disease, because the propensity is there. But it's not just heart disease and stroke, it's blindness, it's kidney disease. And I don't mean just kidney dysfunction, I'm talking about kidney disease leading to kidney failure, requiring dialysis. And that's seen anywhere from 10 to 40% of the population. Imagine 40% of the population needing dialysis. The toll financially, physically, emotionally is huge when you're on dialysis. It also, there's nerve damage. You probably heard of peripheral neuropathy, which is very common. It's painful in these patients. They feel like they're always walking on pebbles. And also gut motility is being hampered because there's nerves in the gut that help to keep things moving. So there's like they can't really digest their food. There's a sense of fullness, and it's not a good sense. There's a link to cancer, and that's really important. There's a strong link to cancer. In fact, I'm going to read you this. Women with diabetes are 27% more likely to develop cancer in their lifetime, and men 19% more likely to develop cancer in their lifetime. Why? Why is that so? Well, it seems to be that obesity and insulin resistance are kind of go hand in hand and dealing with causing cancer in these particular patients. Also, too much insulin, which we see in insulin resistance, increases tumor growth. Not a good thing. So, and other studies have shown that it's maybe cancer itself is a major risk factor for diabetes. So, what's the chicken or the egg? I don't think it's quite clear, but there's definitely a link between diabetes and cancer. I think what most of us are concerned with now is the association of diabetes with dementia. And I will say this to the cows come home. I mean, I'm a cardiologist, but I don't want a good heart with a bad brain. Not now, not ever. And in fact, so what we're seeing insulin resistance in the brain. There's too much insulin, so the brain can't function normally. There's a new term that we use called type 3 diabetes. Yeah, there's type 3 diabetes now, and that's dealing with dementia and Alzheimer's disease that affects the brain of these patients. And that term I think, came out about 2016, so it's relatively new. So it's a bad disease. There's nothing good about it. So the most important thing I can tell you is to know your risk. And when I tell you that 22% of people in this country don't even know they have diabetes. And when you look at you look at prediabetes, and that's seen in, 90 million Americans, most of them don't know it. So what do you have to know? Not just your fasting blood sugar. When you go to your doctor, they're going to order a fasting blood sugar. It could be 90, it could be 100, it could be 110. It could be all over the place because it depends on what your blood sugar registers the minute your blood is drawn. That's it. So what's more important to me is the hemoglobin A1C, which is a marker on the red blood cell. Now, red blood cells, they live for 90 days. So this tells me how your blood sugars have been controlled for the previous 90 days or 3 months. So it's really nice to know that. So let's see, the value below 5.4 is normal. Actually, below 5.7 is normal. I'm more strict. I like it less than 5.4, but really less than 5.7 is normal. 5.7 to 6.4 is prediabetes, and anything above 6.4 is frank diabetes. I mean, I have people in my office that come to me with levels of 7, 8, 9, 10. And a lot of endocrinologists, I've seen patients come to me with an A1C of like 7.5. Endocrinologist says, that's not so bad. Really? It's terrible. That's not a good value to have. So I'm very strict about this. You also should know your fasting insulin number, because if your insulin number is high, you got insulin resistance. And it's just a matter of time before you go prediabetes to diabetes. This is a spectrum. It won't just stay stagnant unless you do something about it. So insulin levels, I like to have certainly less than 8. I'll take less than 10. Anything greater than 10 is considered insulin resistance. And that's telling me that your body is putting out too much insulin. It's really important to know that, folks. Then the other test that I like is there's a couple other tests that if you do specialized lab testing like I do Cleveland Heart Lab and I do Boston Heart Lab. So Cleveland has a test called insulin resistance score. It's actually a calculated value. Boston Heart, the other lab that I tend to use, it does a test called HOMA-IR, which means homeostatic mechanism for insulin resistance. They're both calculated values and they're very similar, but if they're elevated, you've got insulin resistance. And usually that goes along with elevated insulin levels as well. So the other test that I like is called the C-peptide. And that tells me how hard your pancreas is working. Like you could have an A1C, let's say 5.3, 5.4, which doesn't make you a pre-diabetic or a diabetic. But if you have elevated insulin and your C-peptide level is high, like 4, that means your pancreas is working its butt off to not make you a diabetic. But guess what? How long can that last? Eventually, your pancreas is going to poop out, and I'm done. I've got nothing left. And then you become an insulin-requiring diabetic. That's the last thing you want. That's the last thing you want is to become an insulin-requiring diabetic. But if your pancreas poops out, and the C-peptide would tell me that, and it's consistently in that direction, it's just a matter of time, folks, before you become insulin-requiring diabetic. So this is really for everybody to know because of the enormity of this problem, and it's not going away. Those are the tests that I use. There's some genetic testing that's coming out. I'm using one lab. It's called Vibrant Wellness, and they have something called the Cardia X, CARDIAX, and that's by a company called Vibrant America, Vibrant Wellness. And they test for 25 genes for heart disease. They also will test some for diabetes. So it's nice to know, since we do know that it's definite genetic predisposition for diabetes, there are tests that we can tell genetically. I don't use them widely at this point, but I probably will be because I'm getting more and more into the genetic component. Okay, so the next question is prevention, right? What can we do about it? What is the best treatment for it? I've been asked this for years. What is the best treatment for diabetes? My answer is always the same: prevention. Because once you got it, they've been working in the rears. So if we could prevent it, that's ideal. And how do you prevent it? Lifestyle, okay? I don't care what medications you're taking. I don't care. If you were taking medications and that's controlling your diabetes, that's great. But if you aren't incorporating lifestyle management, which we all do as medical advocates, we got to get a better bang for the buck. So it all boils down to diet, exercise, sleep, stress management. You've heard this stuff before. Sleep will definitely affect your insulin resistance. The worse your sleep, the more interrupted your sleep, the greater insulin resistance happens. And as I said before, that's the start of the whole process, insulin resistance. Let's talk about diet. Now, you probably remember this, folks, back in the 90s. What was the big diet craze? Everything was like low fat, high carbs. Remember the Entenmann brownies that were no fat or non-fat chocolate chip cookies by Entenmann's? I mean, it had sugar and all kinds of preservatives, artificial sweeteners, just pure junk. And we were eating that stuff because we, under the guise that it was healthy, that we just need high carbs and low fat. Well, guess what? The country got fatter than ever. And, diabetes became this global epidemic that I've been talking about. Keep in mind, folks, that 42% of the American population is obese. Okay, about 70% or greater are overweight. This is lifestyle. This is what we call SAD, right? What does SAD stand for? Standard American Diet. And that is the issue. That's the problem. 70% of food found in grocery stores processed, ultra processed. That's it. People are eating processed foods like never before. It's easy, it's fast, it tastes good, but it's just junk. And it'll put ravage on diabetes, prediabetes, and metabolic syndrome. So I'm all about diet. What kind of diet? Low carb diet. Okay, you don't need starchy carbohydrates. If you don't eat starchy carbohydrates at all, you will do just fine. Yeah, quinoa is okay. Okay, oatmeal. There's no cereal that's really healthy. Oatmeal is processed the same way that regular cereals are processed. Yeah, it's a complex carb. It will get absorbed a little bit slower than standard cereals, but it's still carbohydrate. It's going to break down to sugar. So it's not a health food that people think it is. Breads, pasta, anything white, forget it. Forget about it. It's not healthy, you know. And let's talk about the brain for a second, since we have this new thing called type 3 diabetes. What is your brain like? The brain thrives with fat. Okay. Your brain is 65% fat. Okay. So the brain thrives in fat. It likes fat. It doesn't like carbs. You may like carbs, but your brain doesn't like it because it actually enhances or produces oxidative stress in the brain. That's the last thing you want as you age, is to have oxidative stress in your brain. That's a bad chemical reaction. We want to cut down on that. So we do that by eating less carbs and more healthy fat. And yeah, if egg yolks are fine. If I hear anyone talk about egg white omelets again, I'm going to go crazy. I mean, that is like so last century, right? There's no need to be talking about egg whites anymore. Egg yolks are high in lecithin. They're high in choline, which is very good for the brain, by the way. And, you know, for years we've known that cholesterol in food does not equate to cholesterol in your bloodstream. So I think eggs are great. It is a complete source of protein. I usually have 2 hard-boiled eggs a day, and then on weekends I'll have an omelet and 3-egg omelet with egg yolks. Okay, I don't eat egg white omelets at all, or any egg whites if I can help it. So it's really about eating healthy fat, avocado, nuts. I usually go for unprocessed nuts. Um, Fatty fish, salmon, mackerel. I mean, I like salmon. So these are healthy fats, not fats mixed with sugar like cookies, cakes, and ice cream. Of course, that's junk. But pure healthy fats are very good. And by the way, no more vegetable oils, please. If I hear anyone talk about canola oil, the Heart Association still will tell you that canola oil is healthy. Where did they get that from? I implore you to go to YouTube and look at the 3-minute video that shows you how canola oil is produced. It's disgusting. And we're eating that stuff. It may be heart healthy, but it's unhealthy for every aspect of your body. And it increases oxidative stress. It's pro-oxidant. We want antioxidants. We don't want pro-oxidants. So in essence, it's substituting a lot of the starchy carbs for healthy fats, keeping your protein intake moderate, not necessarily high. And the other thing is exercise, okay? We all know how important exercise is. Insulin resistance, excuse me, is hampered by poor diet and lack of exercise. So what I can tell people, if you lose weight, exercise, and eat healthy, you're probably going to improve your metabolic issues. And hopefully you can prevent developing diabetes. But it is work. I'm going to tell you, it's a lifestyle change. And most people obviously are not willing to make the change, which it hurts me, to see that people just don't seem to get it. And don't expect the government to tell you what to get about healthy foods. I mean, come on. You see what happened during COVID. Everything's about wearing a mask, washing your hands, and socially distancing yourself from others. That did a lot of bad. And people stayed home, and they made brownies and bread, and they got fatter. I think like 30% of the population got fatter during COVID. And the average weight gain, guess what, folks? 26 pounds. 26 pounds. I've seen it in my own family. So that's what it is. It's pretty easy. It's lifestyle. There are supplements that help. I have my own supplement that I devised called GlucoWise for HeartWise. And the major ingredient is berberine. Berberine is a great herb, and it can actually increase insulin sensitivity. Remember, we want insulin sensitivity. We don't want insulin resistance. It helps to enhance that. It has cinnamon in it. It also has chromium and vanadium and some other vitamins as well. These are good supplements that can help to improve your insulin sensitivity and help with everyday eating and so forth. It's a great adjunct. But I don't go into major supplementation. Those are the ones that I usually take, are the ones that are in my GlucoWise Plus product. And how often when you start seeing, let's say you decide to do a makeover, and let's say you decide to do small baby steps, doesn't matter, as long as you start working, you should start to see some changes within 3 months. So again, since the A1C is a 3-month kind of it takes 3 months to see a major change. 3 months, you will see a change. The A1C won't become normal overnight, but you will see a change within 3 months. If you find a program, devise a program, see a doctor who believes in lifestyle, you need to find a functional medicine doctor. I just happen to be an integrative cardiologist who practices functional medicine. I believe that regular medicine is symptoms, treatment. No, symptoms, cause. What is the cause of this problem? And then we treat. We can't do it all the time, but that's what we aim for in functional medicine. So I think I've discussed about enough. So now I'm going to take your questions. My senior moment, putting my glasses here, I can see what's on the screen here. So thank you guys. And well, let me answer some questions, and I'll do a few concluding remarks. It's definitely work. Yes, it's definitely work. Okay. Thank you. Okay. Is total triglyceride HDL ratio a good predictor of insulin resistance compared to fasting glucose or A1C? No, I would say, as I mentioned before, fasting glucose doesn't tell me much unless it's really high. Definitely, you want to know the A1C. Everybody that's watching this podcast, this session should know their A1C, and know your fasting insulin number. Okay, that's really important. Those are the two things: the A1C and your fasting insulin number. Very important. Okay. Let's see. Everybody's saying hi to me. Hi, guys. Okay. Any other questions? Now, I'm just you notice I didn't talk about drugs. I'm not against drugs. I mean, I'm a cardiologist, so I definitely use drugs in my practice. I have to. But what about this semaglutide, Ozempic, Mounjaro craze? I'm just bringing it up because I know people have questions about it. Again, it should be secondary to lifestyle management. I don't believe in this Hollywood craze, everybody going in there and getting Mounjaro and Ozempic, because what it did, it made it very hard. It made back orders. It took several weeks for my diabetic patients to be able to access these drugs when they really had the need, because some of these people want to lose 15 pounds for a reunion or the red carpet. Are you kidding me? And I really get a little concerned about long-term usage because we're finding out a lot of things about these drugs. First of all, if you have a gut problem, and about 60% of my patients have a gut problem, you may have a problem with these drugs. It's going to be a trial and error. I'm also concerned about the pancreas constantly working this hard. It can be a precursor to chronic pancreatitis, not a good thing to have. How this drug works. It's a peptide, and they bind to receptors in your gut. Okay, the Ozempic is the one we talk about the most. It's the GLP-1, which means glucagon-like peptide. It binds to the receptors in your gut, and it tells your pancreas to put out insulin right after you eat, and which is a good thing because you want it at that point. But then it also tells you, it decreases your food intake because you don't feel so hungry, and you've got delayed gastric emptying. So what happens is that you feel more full, and it's very effective. I mean, you will lose weight on these drugs if you do them regularly. Now, the difference between Ozempic and Mounjaro affects two hormones, GLP-1 and also something called GIP, which is gastrointestinal peptide. And so these are two natural hormones that your body puts out. And so what we're doing, we're binding to these receptors to make this whole process work. So we're taking a natural process and escalating it. Now, I don't know whether that's healthy for the long term, but it is effective in improving your diabetic situation and also in losing weight. So I want to mention that in passing, but I usually don't use these sessions to talk about drugs unless you have specific questions. Okay, let me see. Is there anything else? Okay, I need questions, guys. Do you have patients on? Yes, I have several patients on GLP inhibitors, and they all do well because I wash them like a hawk. And I've had a few that want to escalate one dose to another. There's 3 doses for Ozempic, and there's 5 doses for Mounjaro. And I tell them, okay, this is what you have. Every month I have to see them, usually in person, to make sure they're doing it right and they're feeling well. And then I will increase it to the next stage. But I usually try to keep them on a set dose for a month before I escalate the dose, because nausea is a big deal. You want to make sure they're tolerating it well. I don't want you to trudge through something if you're having side effects and gut side effects. So I think can be very effective, but I do monitor these patients. I think it should be the only way to do it. High triglyceride number. I really think triglycerides should be, well, the labs say 150. They want you to have a level less than 150. I like it more like 120 or so. Triglycerides will clearly change with diet. So that's the reason I believe, should you fast or should you not fast for labs? If you look at triglycerides, cholesterol is less likely to change, but your triglycerides will definitely change according to what you ate the night before. Let's say you had wine sugar, right? Or a high carb meal. It's going to be affected with triglyceride levels. So, but I like it to be more like 120, 130 lower, but the labs usually use 150 as a cutoff. What dose of metformin causes? Okay, wait a minute. Let me make sure I'm reading this right. I don't like these glasses, right? Oh, will high dosages of metformin cause dementia? No. Metformin is the initial first drug that we use for diabetes and also metabolic syndrome and prediabetes. It's generally safe. It was approved in 1992. It's generic now. It used to be, remember some of it was called glucophage. And it's also got some longevity benefits, but it's pretty safe. It increases your insulin sensitivity, or maybe should I decrease your insulin resistance. It also decreases ongoing liver fat production in the liver, so it's got effect on the liver as well. And it's relatively healthy. It does not cause weight gain like some of the original diabetic medications. So it's pretty healthy. And no, I've never heard of anything about dementia with that. I don't think any of the drugs commonly used in diabetic control cause dementia. I think dementia comes from the disease itself, and again, the lifestyle. But I don't think any of the medicines, the old agents, the sulfonylureas, which we used to use when I was a resident and intern resident, that's all we had back then. And they actually caused hypoglycemic reactions. So your blood sugar would drop like it would when you take insulin. And it also caused fat gain. So that's not apparent with these newer medications that we use. Okay, but I don't have to worry about dementia if you're on that. We talked about triglycerides, and yes, GLP. We talked about triglycerides, and I think I just want to make sure I didn't lose anything. So I look at this thing about the triglyceride HDL ratio. It's not a bad predictor. I'm not a ratio guy. Truthfully, I'm really bad with numbers. I can't remember what's normal, what's not. So it's not that it's not a good predictor. It's just that I don't use it myself because I identify more with fasting blood sugar, insulin, A1C, C-peptide, and insulin resistance, or HOMA-IR. Those are ones that I relate to and I use every day. And see, I do either Cleveland Heart Labs or Boston Heart Labs, and I've talked about this in the past. I want to get as much information as I can before I treat somebody. So I always see, like I've seen a few new patients this week, and I tell them, I'm really not interested in your numbers. I mean, I'm not disinterested, but I'm more interested in your risk. Okay. So if your risk is low, I'm not going to put you on a statin more than likely. Okay. If your risk is high, I'm going to have a lower threshold. So it really, that's how I do it as an integrative cardiologist. I individualize my treatment based on a patient's risk. I think that's how it should be. Is it done that way universally? The answer is absolutely no, because the average doctor spends 5 to 7 minutes in the room with you, and the rest is either with a nurse or you're on your own. So because I do differently, I have better communication with my patients. We develop a relationship, and I like to think that better communication spills over to better outcomes. At least I like to think that. And I think that's true. I mean, I wish I could afford to do a study on my patients, but I can't do that. Okay, let me see. Legumes, oops. Wait, I think they're making me, no, hold on. Okay, good. Okay, legumes are the core of my diet with some animal protein. The amount of complex carbs. That's a good question, Dean. It really depends on you. And if legumes are a core of your diet and you do well with them, as far as your gut is concerned, and my question is, are you getting enough protein? You should be getting at least 35 to 50 grams of protein per meal. So if you're an active male, I would be opting for maybe 125. I mean, I'm a protein person, and this depends on whether you're not having kidney disease, but 100 to 125, maybe less for a female. So I don't know if you're going to get that much eating legumes. It is a good complex carbs. I'm not against them at all. I do include those in my diet. Like I had a wonderful bean soup the other night. It was really good. It was just complex carbs, but so I just don't want the core of my diet being that. And at least you're not eating the white stuff, the breads, the pastas, the rice, the potatoes. We know that stuff is bad. We know that breaks down to sugar really readily. So there's a lot worse things you can do than eat legumes. So again, if you tolerate them well and you're healthy, and I know that you are, it's fine. I do not believe there's one diet for all. And anybody knows that. Building muscle helps. Absolutely. Building muscle is, in fact, I will go as far as saying that if you're over the age of 55, if you only have time for one exercise, let it be strength training. Not just because, I am a bodybuilder. I mean, that I just took it to a different level. I believe in muscle as being your organ of longevity. So if you want to live a nice long life and be able to open a window, you better have muscle and you better have strength, because we lose anywhere from 5 to 8% of muscle mass per decade after the age of 35. So use it or lose it, you better believe it. But I think it also is, years ago, we didn't know diddly squat about resistance training. Everything was cardio, cardio, cardio. So we were like relegated to the back seat, right? Now, thank goodness, in the last few years, there's a lot of really good press out there on resistance training, and which of course makes me very happy, because we see the benefits. Yeah, it's great for insulin resistance. It's great. So it doesn't have to be cardio. Weight training is very, very healthy and very useful. Okay, let me see. I love these questions. My grandmother told my mom growing up to diet, to not eat anything white. Well, she was right. Um, you know, the word diet, take off the T, it means die, right? I'm always afraid of that word. I've just seen so many diet failures in my own family. Not me, of course, but I have two sisters, and my younger sister's really has struggled with her weight over the years, and she's never really employed lifestyle, and it's her choice, but you pay the price. And I'm going to say the same thing. My bun plug, as I save up my book from both sides of the table. It came out exactly 1 year ago this week. Can you imagine that? Very proud of that book, because it not only describes my story, what I had to go through when I was hospitalized twice in 19 months, and how I had to step up to the plate. It's really most of it's for you, for the public, to see that you don't have to be a doctor, you don't have to be a nurse to be your own medical advocate. It does take work, but the choice is yours. Because without your health, what do you have? I don't care how much money you have in the bank, you will suffer. So if you want to live a nice, productive life, you better be healthy. And to be healthy, you got to work on lifestyle. I think let me think if there's anything, but these are great questions, you guys. I love it. Your grandmother was white, by the way. I think, high doses of, no, we talked about that. I just want to make sure I didn't lose anything here. I think, we've taken enough time with you for this. I want to thank you all for joining me. I wish you all a happy Thanksgiving. What to eat on Thanksgiving? It's a holiday, okay? I'm not so strict. But, if you're going to have a holiday meal, don't go in there, or with holiday parties, just don't go in hungry. Have a healthy snack before you leave home. Some veggies, grab some veggies first, something with high fiber, it'll fill you up a little bit. But it's a holiday, and I want you all to have a lovely one with friends and family. And I will do a program in December. Haven't quite decided what it is yet, but you'll be notified. And so please share this with other people, because, like I said, you don't have to be a diabetic to appreciate the fact that you may become one, or you may have a metabolic issue that could easily lead to diabetes. And the ravage of this disease is unbelievable. So spread the video, share it with others. Please tell everybody to click on the like button, because it really does make a difference in my ratings. Get my book. It's BeYourOwnMedicalAdvocate.com, BeYourOwnMedicalAdvocate.com. You can get it on Amazon. And until next time, good night. Thank you. I'm very grateful for all of you to be here tonight. And we'll see you in a few weeks. Happy Thanksgiving. Thank you.